Multidisciplinary management of the chronic low back pain patient. A challenge for a new medical model was issued by George Engel in 1977 when he introduced the need for a biopsychosocial model. In 2001, the World Health Organization acknowledged the importance of the biopsychosocial model with the development of the ICF. The International Classification of Functioning, Disability, and Health is a classification of health and health-related domains that include body, individual, and societal perspectives. The use of a biopsychosocial model by physical therapists leads to the need for a multidisciplinary intervention, specifically in our case for patients with chronic low back pain. A couple of definitions that we need to cover. First off, what is a multidisciplinary treatment? What does it include? Well, as stated by Guzman et al. In 2001, and you'll see that reprinted as a Cochrane review in 2002 and 2006, and then adopted by Ravnik et al., a multidisciplinary treatment involves physical, psychological, social, or occupational dimensions. Now, a multidisciplinary treatment must have a physical component, but cannot only have a physical component. Etiology of low back pain, as you know, it's mostly non-specific. 70 to 80% of people will have an onset of low back pain throughout their life. 40% will experience a second occurrence within 6 months. And 85% of patients who present to their PCP have non-specific low back pain that is not attributed to a specific pathoanatomical origin. The diagnosis of low back pain, of chronic low back pain, as we just discussed, the presentation is very multifactorial, but some screening tools that are used are the visual analog scale, the FABQ, the disability questionnaire, the depression scale, and of course we always want to bring up those red flags such as cancer, spinal infection, fractures, and Cotta-Aquinas syndrome. Now on to some treatment options for the chronic low back pain patient. Manual therapy has been proven to help chronic low back pain in several studies. A study by Braunfort has shown that manipulation does not improve symptoms as much as exercise, but it did improve symptoms from baseline. A second study by Mancini-Banpai has shown spinal manipulation with exercise to improve chronic low back pain greater than ultrasound and exercise. According to Macedo et al., those with chronic low back pain show decrease in control of the deep trunk stabilizers, such as the transversus abdominis and multifidus. Benek et al. Took an approach to further investigate these muscles and found that there was bilateral atrophy in the multifidus in those with chronic low back pain compared to those without low back pain. There was an 18% reduction in multifidus in the low back pain patient. Erector spinae had a 3.9% reduction, but was not statistically significant. Both conclude motor control exercises are effective in decreasing pain and disability. Another option your chronic low back pain patients tend to lean towards are the prescription opioids. Deo et al. Performed a systematic review and collected data to show that there's an increase in opioid use along with an increase in overdosing in these patients. Abuse of these is commonly seen in those with psychological issues such as depression that have stemmed from the chronic low back pain. Chronic opioid use may lead to an increase in sensitivity to pain. Overall opioid use has shown modest effect for short-term use. Deo et al. Also found that there is an increase in medical costs for those with chronic low back pain because of unnecessary tests, injections, and surgeries. Those with chronic low back pain are more likely to receive MRIs and present with positive findings, which leads to surgery. It is important to note even those who are asymptomatic may have positive MRI results, so MRIs are not always appropriate for those with non-specific low back pain. MRI rates are increasing, which in turn increases surgery rates. Surgery has been shown to be associated with an increase in risk for complications and poorer outcomes. However, spine surgery may be indicated for those with fractures or deformities. Spinal injections, traction, and modalities have not been shown to be effective in those with chronic low back pain. Rainville, Nguyen, and Surrey are physicians who reviewed several randomized controlled trials in this report published in Seminars for Spine Surgery in 2009. The authors compared surgery to conservative approaches consisting of cognitive intervention and exercise. Across the RCTs, the results showed similar Oswestry score reductions, but the surgical groups had greater decreased pain, while the cognitive and exercise groups had greater decreased fear avoidance beliefs and increased functional mobility and strength. The authors also compared several different exercise protocols for effectiveness and found that they were all effective if they gave patients the message that it is safe to move. The physicians concluded that spine surgeons should partner with physical therapists who will reinforce consistently that normal use of the back is not harmful for the best chance of recovery of full function in chronic low back pain patients. DeFore et al. Published a randomized controlled trial in Spine in 2010 comparing Group A, a multidisciplinary biopsychosocial rehab group, with Group B, an intensive individual therapist-assisted strength exercise group. Group A's intervention included reassurance that there was no serious cause for low back pain and that exercise is safe and effective. Group A did aerobic exercise and trunk stabilizer exercise, postural education, an anatomy lecture, and occupational therapists came in to give back care and lifting technique advice. Group B did individual workouts targeting back and glute muscles in one-on-one sessions with PTs, what we might consider standard PT practice. The authors found that both groups showed improvements in pain and disability ratings with only minor differences between the groups. The multidisciplinary treatment group showed slightly better outcomes over standard PT practice, but the authors concluded, in this case, that the difference was hardly of clinical interest. Looking at the main outcome measures from the DeFore RCT, we see Group A and Group B plotted out to 24 months of follow-up on the visual analog scale for pain ratings. Both groups showed significant improvement, with neither group having a significantly better outcome. Looking at this secondary outcome measure in the DeFore RCT, the Roland Morris Disability Questionnaire, we see that both groups again improved. However, with an MCID of 2 points, we see that Group A had more significant enduring improvements in self-assessed function. This seems to support a multidisciplinary approach. However, the authors did conclude that these differences were not of clinical interest. So what does all this mean for our chronic low back pain patient? What is the bottom line? Well, we can state that intensive, that is greater than 100 hours, of multidisciplinary biopsychosocial rehabilitation programs have been shown to decrease pain and disability and improve function. However, vocational or employment outcomes are inconclusive regardless of intensity. It is worthy to note that there is strong evidence regarding the improvement of function, whereas there's only moderate evidence for the improvement of pain when compared to the outpatient or the non-multidisciplinary rehabilitation or usual care. And here are our references, and we thank you for your time.